And then good morning to all of you in virtual connection. I'm really delighted today to welcome Dr. Ali Saad, who is board certified in vascular neurology and lifestyle medicine and has been practicing for over 10 years as our speaker today. He's a current fellow in climate and health science policy at the University of Colorado and a healthcare without harm climate and health fellow. His fellowship focus is updating medical society guidelines to encourage whole food, plant-forward eating. And this diet is an impactful intervention for the prevention and often reversal of most chronic diseases and significantly reduces carbon emissions in our food system. The title of his talk, as you see, is Food, Our Most Powerful Climate Policy. Thank you, Dr. Saad.
Thank you for the kind introduction, Dr. Eisenberg. I'm just going to pull up my presentation. All right, wonderful. So thank you all for having me today. I'm excited to be here in Seattle, and we're back in person, which is wonderful. So here's my disclosure slide, and here's our outline. So why am I doing this work? Well, I started my neurology residency in 2009. I finished my stroke fellowship, and then my first job out of training was in academics. As an attending, I first wanted to get to a point where I had streamlined the acute care of my stroke patients. And once I got to that point, I wanted to focus on prevention both in the hospital and in the clinic. And in doing my research, one of the most important studies I came across was the Inner Stroke study, which was a global epidemiological study that showed that 90% of the global stroke risk, when you lump both ischemic and hemorrhagic stroke together, 90% of that risk is accounted for by 10 key lifestyle risk factors that are all modifiable. And of those 10 risk factors, 6 are directly related to diet. And not surprisingly, the Inner Stroke study was based on the Inner Heart study that preceded it and found similar findings for heart disease. And as I continued to read, I found that diet was such a fundamental risk for so many of the chronic diseases that my patients had outside of just neurology. And really, the medical system was not set up in a way to give people the dietary interventions they needed and the dietary resources they needed in an affordable and accessible manner and with the necessary follow-up that was needed. And I just really felt that I was churning out patients out of the hospital and not really providing value care and not really respecting the time of my patients and my colleagues. And so after practicing for 6 years as an attending, I got to a point where I felt the care I was providing was no longer meaningful. It didn't feel high value, and I didn't feel I was doing the right thing for my patients. And as I continued to explore, I found that our broken food system not only affects the health of ourselves and our patients, but also has a significant impact on our environment. And I found that there was a lot of connections between environmental health and human health. And in order to explore that further, I joined the University of Colorado's Climate and Health Program, which has been around for about 5 years now. And I'm in the middle of towards the end of my fellowship right now. I'll be completing it in June. And my focus is food systems. So I'd like to share my perspective with you about that today. All right, so how does food affect our health? Many of our issues with our food system have common problems and solutions for both human health and planetary health. And this is a concept embraced by the CDC, labeled as One Health. And I think that food is not only the most fundamental way that we're linked to our planet's health, but it's also one where any patient and any physician, regardless of their background, can engage in a meaningful way, which is something I'm going to go over with you. So this is a really powerful quote from the American Society for Nutrition. And a lot of people still think that smoking is the greatest threat to public health. But people are smoking less, and diet and its related diseases are increasing in prevalence. And so now diet has become the single most important modifiable risk factor. And this finding is based on multiple studies, including a large one from the Lancet that I've cited down here. So how is it that poor diet is now the biggest contributor to our poor health, and yet it's not the focus of our medical education, of our clinical practice, or our reimbursement model? And if you think about it, there's a best practice advisory, those pop-ups that come up in Epic and tell you to do stuff. There's one for smoking, and it tells you, have you asked your patient about smoking? Have you screened them? And if you do that, there's a billing code for it. We don't have something like that for nutrition, or at least something that's not as readily available that people are familiar with. So that's some food for thought. On average, people in the US are way sicker than they need to be. This is the CDC's data on chronic disease in the US. About 6 in 10 Americans have one chronic disease, whereas 4 in 10 Americans have 2 or more. And these are the common diseases that we're talking about: heart disease, stroke, cancer, chronic lung disease, diabetes. Seeing our patients in the hospitals or clinics without at least one of these diseases is certainly the exception to the rule. And diet is the primary driver for most of them. From a mortality perspective, 7 in 10 Americans each year die related to chronic disease. And of these chronic diseases, the top 3, stroke, heart disease, and cancer, account for half of them. And it's important to look at the data in the US, not only because we live here and this is where our patients are, but a look at what's going on in the US as a look at what's going to happen in the rest of the world as countries become industrialized and their diets in accordance become more westernized, ultimately leading to similar dietary patterns. And we see that here. So here's some international data from the WHO, and it lists the top 10 diseases in terms of morbidity and mortality worldwide and how it's changed over time. In the y-axis, we've got the diseases arranged in terms of descending order by number of deaths. And then on the x-axis, we have number of deaths. So heart attack causes the most deaths, whereas kidney disease is at the bottom. And you can see that all of these diseases are color-coded as either blue or green. The blue diseases are non-communicable diseases. And there are a lot of the same ones we saw in the US data from the CDC: stroke, heart attack, COPD, Alzheimer's. And then the green ones are the communicable diseases, in other words, the infectious diseases. And we also see that the white circles in each disease represent where the mortality is in the year 2000, whereas the colored circle represents where the mortality is in 2019. And you see with all these blue or non-communicable diseases, the number of deaths has gone up, whereas with all the green diseases, it's gone down. And this makes sense because as countries become industrialized, they simultaneously provide better sanitation and reduce the risk of infection, but the industrialization also produces a westernization of food systems. And stroke is a great example of nutrition's role in chronic disease. We do have newer data since the 2012 InterStroke study, and this is data published by the World Stroke Organization in something called the Stroke Fact Sheet, cited here below. And it largely reproduced the same findings as the InterStroke study on a global scale. Again, 10 risk factors account for approximately 90% of the global stroke burden, meaning that 90% of strokes that we see with our patients can be prevented. And again, 6 of these risk factors are largely related to diet. You see these over here: high blood pressure, diabetes, obesity or overweight, high cholesterol, and kidney dysfunction. In accordance with the stroke data we're usually familiar with, high blood pressure is the greatest risk factor. And an interesting thing I want to point out is actually over here on this side, which is air pollution. That's not something we commonly think about when it comes to stroke or heart attack risk, but air pollution is becoming a significant contributor. And this is not just based on a few case studies in a few cities. This is actually something that can be found on the AHA's website. And depending on what you define air pollution as, air pollution accounts for anywhere from 20 to 34% of stroke and heart attack risk independently. So it's becoming a significant social determinant of health. So let's delve a little bit deeper into what I mean by poor diet. And I'll just give you a few seconds to look through this slide and absorb it before I go into it. So the problem with our modern diet is it's one of deficiency in whole foods, also known as unprocessed or real foods. And this is clearly demonstrated in this graph. So this is from the Lancet Global Burden of Disease study. And the dietary patterns are ranged from highest to lowest with respect to the amount that they contribute to death on a global scale. Most deaths are attributable to high salt and not enough whole grains, fruits, and veggies. And these are our primary sources of dietary fiber. So basically, we're not getting enough of the foods that are good for us and too much of the processed stuff. Diets high in sodium and foods high in sodium are a good surrogate marker of foods that are heavily processed. And here's a breakdown of the typical American diet. 60% of the typical American diet is processed food, meaning food that has added fat, sugar, salt, and other additives and chemicals. And our issue is the 60 versus 6%. We're getting too much of the bad stuff, not enough of the good stuff, right here. Although we have 12% plant products in the diet, only half of that is unprocessed, fruits, veggies, whole grains, etc. The processed stuff is going to be stuff like candy and juice, which happens to come from plants. And so from a health perspective, we don't need strict veganism or vegetarianism, but we do need to be plant-forward or plant-based, meaning that most of our food should be coming from plants, and most of it should be real food and not processed junk food. And this is what I tell my patients. How does food affect our planet? So this is a graph of atmospheric carbon dioxide emissions over time. We have the CO2 emissions in the y-axis, and then we have time in the x-axis, starting from about 1 million years ago and leading up to today. And what we see is there's a natural fluctuation in the amount of atmospheric carbon dioxide over the ages. You see this natural cycle. When CO2 levels are high, the planet tends to be warmer. When CO2 levels are low, it tends to be cooler and tends to correlate with ice ages. But what happened around the 1800s is we began producing emissions at an unprecedented rate. And around 1950, we began to exceed historical highs. And it was by the 1980s that these historical highs began to translate into more frequent extreme weather events and higher average global temperatures, the combination of which we refer to as climate change. And the reason for the global temperature rising in the last 200 years in this significant way is twofold. Firstly, there's the Industrial Revolution, which took place in the late 1700s to mid 1800s. And what happened in the Industrial Revolution is we started to use fossil fuels on a large scale. So no longer were people burning coal and fossil fuels in their homes just to heat them up. They were also using it to produce in factories and wealthy nations across the world. And industrial agriculture in this way was, well, I'm sorry, I should backtrack. Just like, the textile industry and other industries were industrialized, agriculture was similarly industrialized. And initially this was a boon for public health, because you think about what life was like back in the 1800s and before that. Most people were dying of malnutrition, infection, and injury. And overnutrition was not the problem that it is today. Most people were malnourished if they came from low wealth communities. So this was a boon for public health by producing high calorie animal products and staple crops like wheat, because it was pulling millions of people out of poverty and starvation. And it also allowed people to pursue higher education because they didn't have to do as many tasks that could now be automated with factories. But the price of this was not only producing more carbon dioxide, but also depleting our natural resources at a rate beyond which the planet could replace them. And our natural resources like forests, natural bodies of water, healthy soil that's undisturbed, aren't just needed for functioning ecosystems, but we also need them to sequester carbon dioxide. The second reason for global temperatures rising significantly over the last 200 years is the population began to explode. So the population has been rising for the last few hundred years steadily, starting at the 1600s over here. And around the time of the Industrial Revolution, it picked up a little bit, but it wasn't until World War II was over and people had the time, the money, and the resources and the safety to be able to reproduce more. And so then we had the baby boomers, resulting in a significant population explosion over here. So that's the second reason. But I do want to be clear that overpopulation per se is not really the problem when it comes to climate change. It's more our consumers' lifestyle and our dietary patterns that are unsustainable. And as countries become industrialized and rise from poverty, their typical dietary shift is more towards one of a Western diet that's low in fiber and higher in animal products. And they also tend to have less babies, and so the population tends to slow down. That's generally the trend. There are exceptions to that rule. One that comes to mind is the Arab Gulf nations, where they continue to have children at a high rate, despite being a developed country. So how does our modern diet negatively impact the planet? I like to kind of think of the planet as an arch bridge. It's got pillars on either side to support life. And those pillars are clean air and water, having just enough carbon dioxide in the atmosphere to keep the planet warm enough to sustain life, having adequate living space and healthy soil, but also predictable weather so that the plants know when to bloom, the animals know when to migrate, and farmers know when to plant their crops in a safe way. And all life places stress on that arch bridge, the plants, the animals, and people. And for millions of years, this has been just fine because we have plenty of resources on the planet to absorb the carbon dioxide and the waste we produce and then recycle it into other things again. But what happened with industrialization is people did two things simultaneously. One, we were breeding way too many animals into existence, and we were also simultaneously destroying plant life. And so our planetary checkbook of resources was no longer balancing out. We were producing all these animals, but we didn't have the plants necessary to feed them. And we also didn't have the plants necessary to absorb the carbon dioxide and the other greenhouse gases being produced by those animals. So it's really just simple math. And what I'd like to point out to you here, it's a little dark on the slide, but at the center of this arch bridge, there's a stone right in the center, and that's called the keystone. It's the last stone that's placed in the construction of an arch bridge. And it's the most important piece because it locks all the stones into pieces and allows that bridge to bear weight. And I would argue that the keystone to our planet is our food systems. And the evidence for this comes from a seminal study published in 2019 called the Eat Lancet Commission. So this study was commissioned to see how can we feed a growing global population, estimated to be kind of level off at about 10 billion, without depleting the planet's resources and also without significantly worsening climate change. And if you want to watch a 25-minute summary of this video, you can scan this QR code. I think they did a really good job summarizing the evidence. But from a climate change perspective, our general goal is to stay below 1.5 degrees of average global temperature increase compared to baseline before the Industrial Revolution. Because at that point, once we're above 1.5, climate scientists expect that we're going to have significantly more extreme weather events and catastrophic climate change. So that's where that 1.5 comes from. And it was agreed upon in the Paris Agreement that's what countries would strive towards. And I'm bringing that up, the 1.5 degree target, because the Eat Lancet Commission had two key findings in relation to this temperature goal, which I found really quite surprising. One was that without radically changing our food systems, even if we do all these other green measures like switching to electric cars, divesting from fossil fuels, we're not going to hit that 1.5 or not going to stay below that 1.5 target. And the second key point is by doing food systems alone and not addressing these other things, we can reach that 1.5 degree target. And that's because our food systems contribute to climate change in so many more ways than simply producing carbon dioxide and other greenhouse gas emissions. And this is how. So this graphic is from Our World in Data, which we've all become very familiar with because of COVID. But it breaks down our global greenhouse gas emissions. And you can see the general breakdown is most of our greenhouse gases are non-food related, and this non-food is basically the energy sector. Whereas the remaining 34% is related to our food systems. So that means about a third of global greenhouse gases are related to our food systems. So that's a key fact. Another key fact is food systems and poor nutrition are our biggest social determinant of health right now, more than smoking. So let's break down this 34% further. And you can see most of this is related to the green and the red sections, which is essentially agricultural land use. But you look at these other sections and the packaging, the transport of food, meaning the import, export of food, and food waste are really a very small relative portion of our greenhouse gas emissions. It's really the forests we're clearing to produce these crops, the crops that we're using to feed these animals, and then the methane and our other greenhouse gas emissions related to animal agriculture. So direct and indirect land use are our biggest greenhouse gas emitters from the food sector. And I want to show this older version of the data for two key points. One is you see over here, the food sector did contribute about 26% of our global greenhouse gas emissions, and just over the course of a few years, it's gone up to 34%. So it's rising rapidly. And with our status quo in terms of how we produce and eat food, we can probably expect it to continue rising. That's one point. The second point is most of our emissions are related to feeding livestock rather than feeding people directly. And so we do the math. We take 31% from livestock and fisheries. We take 6% from crops for animal feed, and we take 16% from land use for livestock. That adds up to 53%. So 53% of these emissions are related to animal agriculture through a combination of land use for housing and land use for growing crops to feed these livestock. And so you think about what if we were to use that land to feed people directly? We would only need a small portion of that. In fact, with the amount of food we produce simply to feed animals, we can use those crops to feed the global population several times over. And the math works out that there really shouldn't be any starvation, and there's still plenty of food left over, meaning we don't even have to produce all this food. And this is because, you take cows as an example, the protein content in plant food, you need about 5 to 6 times as much to feed a cow compared to a human being. And a typical human being is going to eat a lot of cows over the course of their life. So you think about how much an average person would probably eat beef. So, let's say maybe 3 times a week, 52 weeks a year, the person living about 80 years, that's 12,480 cows. And that's a lot of crops that have to be grown to feed that cow. That's a lot of water to water those crops. That's a lot of fertilizer. That's a lot of pesticide. That's a lot of carbon dioxide and methane produced both directly and indirectly from that process. And, you think about, there we go. So you think about how we'd have all this land left over if we're just requiring a small portion to feed people directly through these crops. We'd have all this leftover land, and this land could be used to house people. This land could be used to rewild the environment, meaning you allow this land to just have the indigenous plants and animals occupy it again. This promotes biodiversity, and it also promotes carbon sequestration in the form of undisturbed forest, soil, and ocean beds. Because we think about chopping down trees, and then you have less trees to absorb the carbon dioxide through photosynthesis, but that's just one of the ways that our planet sequesters carbon. In fact, about a third of the carbon dioxide produced by people is absorbed by the oceans. And what happens when we acidify the oceans and we drag up ocean beds with fishing nets, that disturbs the soil and it releases carbon dioxide. And the acidification of the oceans also releases carbon dioxide and reduces the amount of carbon dioxide that the ocean can sequester. Similarly, when you till soil, that disturbs the root systems and the microbiome of the soil, and it also makes the soil more easily able to blow away with high winds, to wash away with flooding, and so you lose that carbon sink in the soil as well. Another advantage of lessening our animal agriculture is we're lessening the amount of antibiotics used in factory farming. So, we don't really have special antibiotics we use on animals and farms. It's the same antibiotics we use to treat skin infections, meningitis, pneumonia, the same things we treat people with in the hospital. And what happens is these animals are packed so closely together in these factory farms that they're in their own feces, there's no personal space, and they're very high risk for infection. And so this necessitates the use of prophylactic antibiotics indiscriminately. So they're not giving these animals antibiotics because they're sick, they're doing it to prevent them from getting sick. And because they're overusing these antibiotics, it leads to antibiotic resistance. And so that's one of the reasons we're seeing more antibiotic resistance in our patients these days, because we're using these same antibiotics in animals. Similarly, having animals in such close quarters allows them to be petri dishes for the formation of zoonotic diseases. So this is where we get things like swine flu, like avian flu, like MERS, and some people theorize COVID-19 as well. Having less animal agriculture also means less manure being dumped into our waterways, which acidifies and pollutes our waterways, making them unsuitable for marine life, killing fish and aquatic plant life, but then also leading to less drinking water available for us in our aquifers underground. So this is why I'm so focused on food systems from a public health perspective, because it has so many insidious connections to climate change beyond simple photosynthesis. Here we go. So for those thinking, well, why don't we just eat local animal products and cut down on greenhouse gas emissions? Because that should be fine if we just eat locally and support small family farms. But eating locally is certainly better than importing, but it's not going to be the most important factor with regard to your carbon footprint in terms of food choices. So this graph has tiny print, but we're really just looking at the colors. And we see that the colors here are mostly green, orange, and brown. We've got in the y-axis common foods arranged from most carbon emitting to least carbon emitting. And the x-axis, we have the greenhouse gas emissions per kilo of food. And the colors break down the components of that carbon emission. And right above this orange dotted line, it separates the generally most polluting foods from the least polluting foods. And you can see that although there are exceptions, by and large, animal products are going to be the most polluting over here in the top part. And then when you look at these three colors, the green, orange, and brown, so the carbon footprint largely comes from land use, farming, and animal feed. And again, just like we saw in the data from a few slides ago, the other colors like processing, transport, packaging, shipping, this accounts for a minority of the carbon emissions for that particular food. It barely registers on these bar graphs. So this is why, regardless of whether you eat locally or you're importing animal products, it doesn't really matter where they're produced with regard to carbon footprint. It's more that you're eating those things, and they produce a lot of carbon emissions. And in fact, you see at the very bottom of the graph, there's some negativity, meaning there are specific foods like nuts and fruits, which grow on trees, that actually absorb carbon because they grow on trees. So by promoting those foods, you're promoting tree planting. And so then you might say, well, we can't just eat fruits and veggies. We need protein-dense foods, right? But this graph represents protein-rich foods specifically and measures the carbon emissions with regard to protein content. So again, you have the y-axis representing types of foods, arranged from most emitting to least emitting, and the x-axis representing greenhouse gas emissions in relation to the protein content of that food specifically. So here, greenhouse gas emissions per 100 grams of protein. And again, above the dotted line, the most polluting products are typically animal products, and below the dotted line, mostly plant-based products. And even when you look at eggs and fish, they still produce anywhere from 3 to 10 times more greenhouse gas emissions compared to plant sources, like tofu, beans, peas, and nuts. So again, plant products, even when you're measuring them with regard to protein content, are going to be better for the environment. And aside from producing less greenhouse gas emissions overall, you also see that these bell curves are pretty narrow for the plant products, meaning that the greenhouse gas emissions can be produced in a pretty predictable manner, as opposed to the animal products, which have a really wide bell. And so they're kind of harder to predict depending on the various variables. And this is basic, thermodynamics. The further up you go on the food chain, the more unpredictability there's going to be. And so here's some models of what global land use would look like if we were to be more plant-based. So starting here at the top from our current diet, going to more and more plants as we work our way down. And of course, following the logic of this argument, a vegan diet would lead to the least emissions, but obviously this is not going to be the most practical or desirable goal for a lot of people. And so similar to how we don't need strict veganism or vegetarianism when it comes to good human health, you also don't need it strictly for good planetary health. And the takeaway from this graph for me is that reducing our consumption of animal products, just reduction, not even eliminating it, is a huge win for climate change. You look over here, if you just cut out beef and ruminants, so red meat basically, we're cutting down our agricultural land use to half of what we currently use. Half, just by reducing red meat. If you cut out dairy too, we're now down to cutting out 75% of our current land use. So that means we can still eat fish, chicken, eggs, and really just use 25% of the current agricultural land that we use. And to give you a more concrete sense of how much land that is, 75% of our agricultural use is the size of North America plus Brazil. That's about 2 continents. That's how much of our land around the world we need to grow crops to feed animals and people. Most of that is to feed animals. And so this dietary pattern is what would be considered sustainable for someone that doesn't want to be a strict vegan or vegetarian. And the Eat Lancet report actually specifically quantified how much animal products would be acceptable to eat from a sustainability perspective. And what they came up with is you could, on average, eat 1 dairy item a day and then 1 anything else item every day, with that anything else being some sort of animal product. The exception would be if that second item is red meat, it really should be up to 1 serving a week. But for people eating the typical American diet, this is really not a huge cultural shift. This basically means for breakfast, you're having some cheese or yogurt in your breakfast as part of it. Your lunch can be made entirely of plants. It doesn't have to be a salad. It can be something Indian or Thai or Mediterranean that's going to be made of beans or lentils or tofu. And then for dinner, you're having chicken or fish. And so not a huge behavioral shift culturally or gastronomically for most people. I think, quite palatable actually. And so the last section of this talk, how can we make better choices? So when we define and choose healthy food for ourselves and our patients, we need to be able to explain it in a simple and efficient way, because we're addressing a lot of things in the clinic and taking care of a lot of acute life-threatening issues in the hospital. But if we don't make it a point to talk about diet for even 30 seconds, we're sending a message to that patient that diet's important, but it's not the most important thing because I'm not even going to mention it to you. So we need to prioritize minimally processed, or also known as whole food or real food. And I think a good definition of highly processed food is once the original food that it came from is no longer easily recognizable, or you add so much oil, salt, sugar to it that it becomes, it kind of outweighs the nutritional value of the original food, that's when I consider it highly processed. That's typically what I tell people. And whole foods go beyond fruits and veggies. They also include nuts, seeds, legumes, and I typically tell people go to your produce section, and if you have a bulk section like this where you put stuff in plastic bags, that's where you want to get the bulk of your food because they're usually single ingredients. And nutritionally speaking, you might see that some mushrooms and jackfruits are textured to kind of mimic meat, but nutritionally speaking, beans and lentils are the meat equivalent of in the plant kingdom because of their high protein and iron content. And unlike The other thing with beans and lentils is they are a core food in the 5 blue zones around the world. So these are the 5 areas of the world where people live past age of 100, and not only live past it, but are functional and independent. And they all eat beans and lentils as part of their diet in some form. So unlike animal products, plant foods contain fiber, no cholesterol, and are generally low in total fat and saturated fat. So I like to tell people that you take a handful of walnuts versus a 6-ounce piece of salmon. They're both going to provide more than your daily recommended amount of omega-3s, but the walnuts package it in a healthier way. And not only do plants provide the adequate micro and macronutrients that we need in our diet, they also kind of cancel out the negative components of some animal products. So you take a beef burger you might have at a barbecue, for example. If you have it with a salad, the antioxidants from those plants are going to bind to the free radicals from the char on that meat. The fiber is going to interfere with the absorption of excess fat and saturated fat in your gut. And so having plant products with your animal products is certainly better than having it with the animal products alone. But physician and healthcare professional counseling at the bedside can only go so far. Ultimately, we need to have our medical society support guidelines, and more importantly, have these guidelines inform federal and state policy. The Canadian government did a great job of reviewing the data and showed that a plant-forward diet is not only the healthiest way, but also the most sustainable way to feed our population and address food security. They no longer recommend dairy or meat as specific food groups. They recommend specific nutrients, like you need protein, you need fiber, you need these vitamins, you need these minerals. And they give the available foods that can provide these inadequate resources, rather than saying you need a serving of fish or you need a glass of milk every day. And this is important because it allows people to choose a diet that's culturally congruent for them while meeting their nutritional needs. And it provides animal products as an option, but not the default as to how you should be getting those nutrients. So economically speaking, if we don't need meat, dairy, and eggs as mandated food groups, then we no longer need government subsidization of their production. And from a social justice perspective, vulnerable populations that get a lot of their meals in public schools, in prisons, those relying on SNAP benefits, formerly known as food stamps, don't need to necessarily have dairy milk as part of their government-provided diets. And having dairy in the US dietary guidelines is now being called by some a form of systemic racism, because if that's where you're getting the bulk of your food, and the government is saying milk has to be part of your plate because that's what we recommend as a healthy diet, you are giving people that are lactose intolerant that milk and making them sick. And the majority of people in the world are actually lactose intolerant. We now see that the ability to digest lactose as an adaptation rather than lactose intolerance being a deficiency that people have. And from the farmer's perspective, having no government subsidy of animal products means there's less financial incentive to produce those products, which are generally more costly and risky to raise livestock as opposed to plants. And I do want to, highlight the reason that Canada was able to do this is because they came out publicly when they made their last iteration of the dietary guidelines and said, we are refusing to meet with private industry in creating these guidelines. We are only going to meet with scientists and healthcare professionals and reviewing the data and making these guidelines. And that's how they got this evidence-based nutritional guide. This contrasts in the US, where we have the USDA being responsible for creating our dietary guidelines, while simultaneously being responsible for serving the financial interests of private industry. So they design our dietary guidelines, but they're also responsible for commercials you might see like milk does a body good. And so there's an inherent conflict of interest in that. The people that comprise the USDA also typically come from private industry, mostly animal agriculture. And so again, there's a conflict of interest that's self-serving. We really can't have commercial interest come into play when designing our dietary guidelines if we're going to be evidence-based. Another way to make healthy choices or better choices is supporting our local farmers. And choosing local means supporting your local economy, because it means that that local population will not have to rely as heavily on outside sources to, like outside states, countries, and corporations to provide your food, and you can be more food secure as a population. Because if manufacturers can outsource the production of a product at a cheaper price, they will do it. And this is something we've seen in the fashion industry, where a lot of our clothes are produced abroad. And the people producing these products are exploited in terms of cheap labor, poor working conditions, and poor standards of living. And the same thing happens to our food, where actually we export a lot of our crops to feed animals abroad and vice versa, because these crops can be produced abroad for cheaper. And so this disincentivizes the production of crops locally. It puts farmers out of a job because they can't really compete with these cheap markets. And often what animal agriculture will do when it comes to small family farms, when it comes to promoting animal agriculture, is they'll say, well, we're just feeding people. And also you can't shut down animal agriculture. What about the poor farmer? What about the poor farmer's small family farm? But in reality, small family farms account for less than 1% of how animal products are produced in this country. And most farmers have to work with corporations that tell them when to feed their animals, how much to feed their animals, what to feed their animals, and then give those animals back to the corporation for processing. And they don't really have the autonomy over that farm. So really, they're cogs in the system, unfortunately. So our food system is not only unsustainable, but it's also not resilient, and it doesn't provide the protections needed for our most vulnerable people. We saw this in our fragile food system being exposed during COVID-19, where pretty much every city around the US, we had lines of people waiting for food from the government. And here are some national stats from my home state of Colorado. We make more food than we need. It's mostly from corporations, not small family farms. And on average, 11% of people nationally are still food insecure. Any community that's going to be low on resources or options is going to be worse off when any system is stressed, and food is no exception to that. For low wealth communities and for BIPOC communities, food is not only no exception to climate injustice, but it's also the bedrock of it. Because you think about how people ate for thousands of years. Most people ate mostly plant foods because they were cheaper and easier and safer to produce. Remember, before we had industrialization, refrigeration, antibiotics, those animals needed to be hunted and their meat needed to be preserved. So there was more risk than we have nowadays. And so people would eat animal products as a small portion of their meal, and often mostly on holidays. And that's why we'll have things like Thanksgiving turkey, like Christmas dinner, because it's a holiday. It's a special event when you're going to go out of your way and invest resources to get those animal products into your diet. But obesity and the consumption of animal products were both patterns largely seen in the rich. But the Industrial Revolution comes along, like I was talking about earlier. It makes animal products cheaper and easier to produce at a large scale, pulls people out of poverty. It's great, but there's an overcorrection. And so by eating all these animal products and staple crops and having less diversity and less fiber in your diet, you are overcorrecting and reducing the amount of fiber in people's diets or increasing the amount of fat. And despite that, the government continues to subsidize these foods. And so now the cheapest food is also the unhealthiest food. And that's why in the most at-risk communities, the cheapest and most affordable foods they can get are going to be $1 burgers from McDonald's or the processed foods on the shelves of Walgreens or CVS. And these people are going to develop disproportionately more chronic disease, lead to more disability, increase health care spending, loss of productivity, and early death, creating a positive feedback loop that's going to make them unhealthier and have less wealth. And this cycle generates more money for our food and health systems. And so there's little incentive to change it. So the injustice we see in our food system surrounds us every day. We see it every day at work with our patients. And we see it every day at home when we see commercials that are largely about junk food or the medicines needed to treat the complications of that junk food. And to change our food systems, we need, it's not an insurmountable task. And it's not going to be accomplished by a carrot or a stick approach. We're going to need both. The carrots are that the younger generation is demanding better food. They're demanding better treatment of employees. They're demanding more just environments at work and climate justice. And they're increasingly adopting a more flexitarian diet. Companies can profit off of this by aligning their values with those of their consumers And political leaders can capitalize off of this by endorsing policies that reflect their constituents' values. On the individual level, we can't really sell a life of austerity that vilifies humanity for wanting modern conveniences. We have to frame the dietary shift as a way to give people back their time, their money, their happiness, and autonomy. And it needs to be a better deal than the status quo. We can't be selling asceticism to people. The framing also has to be about this being people first and about promoting human flourishing. It can't be about protecting the planet as a good in and of itself, because it's not a fair thing to ask of people that are not having their basic needs met. People can't care about something greater than themselves if they're already struggling to live. It can't really, the climate justice can't be seen as a charitable cause for wealthy people. It's got to be seen as the solution for everybody. And then the stick approach is that physicians need to incorporate diet into medical society guidelines for the prevention and treatment of our most common chronic diseases, like stroke and dementia. We need to go to major neurological societies' websites and see position statements and guidelines on how diet is important. Because once you have those position statements, they define standard of care. Standard of care is what's going to inform hospital metrics. And it's also going to inform what Medicare and Medicaid are going to reimburse. And so if hospitals are not meeting standard of care, they can get sued, they can get their accreditation status lost, and they can lose income from Medicare and Medicaid. Having this as standard of care is also going to inform what's adopted into our medical school curricula, what is on our licensing exams, what's on our board exams. And a financial argument can be made for preventative health through diet, because it saves Medicare and Medicaid dollars, and that means less taxes down the road, and it's more money for the government to use on other things. And if CMS can change how they're paying for healthcare and spending less than 17% of the GDP they're currently spending on healthcare, then private industry and private insurance has to follow suit in terms of what Medicare and Medicaid are doing, because they drive the market. So I really see our healthcare system as fixable. And we really need to save ourselves from our poor health and our patients' poor health, because it's also something that's contributing to our moral injury and our burnout. Medicine's always been hard. We're not burnt out because the work is hard. It's because we're seeing that we're putting people back into these environments that's making them sick and not really having the power to address these things. And I think as healthcare leaders, we have largely been relegated to being technicians at this point. We're no longer at the helm of public policy. We need to be at the helm of public policy, not only for our own burnout, but also to actually make impactful changes to our society. And physicians remain one of the most credible voices, and healthcare workers remain one of the most credible voices and powerful agents of change. And I'm very hopeful, because we do have programs that already exist and address lifestyle and are reimbursed by Medicare, importantly. This is the Ornish reversal program for cardiac disease. It's reimbursed by Medicare. It's a multidisciplinary program that focuses on diet, exercise, emotional support, and is reimbursed by Medicare to help reverse heart disease. It's available all around the country. And it's something that Dr. Ornish started about 40 years ago at this point, but it took 30 years of advocacy and research to get it approved by Medicare. It was approved by Medicare in 2010. But our neuro patients can't wait that long. And they really shouldn't have to, because now those regulatory waters have already been navigated, and a lot of the research has already been done. So I think from a neurological perspective, this is something we can piggyback on. And we can have a similar program for brain health that is reimbursed by Medicare and Medicaid. So here's some ways that you can take action and ways that you can learn more if you're interested. The Gaples Institute at Harvard has this great 10-minute interactive webinar on the intersection of climate and health. You can scan the QR code to do it. It's free. You can also join the Medical Society Consortium on Climate and Health. So this is a consortium of about 20 state chapters and about 50 medical societies in the country. A lot of the major medical societies are in it. And they allow you to connect with legislators in your state. You can testify for climate or health-related bills that are coming up. And you can also attend on-the-Hill meetings, similar to how the American Academy of Neurology has on-the-Hill meetings. You can go with the consortium and also meet with your state legislators. You can also find free CME at the American College of Lifestyle Medicine, on food as medicine. And as of next month, we should have the first neurology member interest group. So this will be a great gathering place for clinicians working in neurology to collaborate with other healthcare professionals at ACLM and be an epicenter for research and collaboration with other institutions and societies like the American Academy of Neurology. And then lastly, here's my email and my QR code for my Twitter if you'd like to reach out to me. I'd like to thank the Seattle Science Foundation for hosting me, Dr. Nancy Eisenberg for the invite, and the University of Colorado's Climate and Health Program, and the Climate and Health Foundation for supporting my work. Thank you all.
Thank you so much. Thank you so much, Dr. Saad, for an amazing talk. And I'm going to yield the questions. If anybody has any questions.
I have a quick question.
Yeah,
Please.
Dr. Elliott.
Yes, excellent talk.
Thank you.
I was interested in your opinion about the role of intermittent fasting for our patients or people in general.
Mm-hmm. So, I mean, I'm certainly not an expert on intermittent fasting. I couldn't really tell you the data probably at a granular level that you would need it for. But I know it is something that's being used by a lot of people in lifestyle medicine. But I can provide some information for you later for sure.
And I'll just add a comment. I'll point you also towards Dr. Walter Longo's work, and there is some emerging science on the impact of fasting mimicking and intermittent fasting on promoting autophagy and the benefits in neurodegenerative disease as well as in cancers. Let's see if there's other questions. I had a question for you, Dr. Saad.
Yeah.
And it's really a practical question. So you see patients mainly in the hospitals, we were talking earlier, and thinking ahead to sort of the ideal world state where our health system would be working, how would you paint us a picture of that encounter after the hospital in the outpatient setting for somebody who's had a stroke? Who are the team members who you envision caring for that patient? What does that look like from your perspective, as we've all acknowledged that our current system is not adequately caring for individuals with chronic diseases that are, can be better treated?
Yeah, that's a great question. And there's so many ways that food touches our patients both in and out of the hospital. So, what I would see in an ideal world is someone gets admitted to the hospital, we put in their orders as part of our order set for whatever condition they have. And the default order should be a whole food, plant-forward diet, meaning that's what's ordered for them because we consider there is at least moderate evidence to support the prevention and treatment of their chronic disease. And so that's the diet they get ordered. But at the same time, we respect people's autonomy. And if they want to order something else, they have the option to opt out. But the default is what's evidence-based and good for them. So someone gets admitted to the stroke unit, they should not have the current default for most hospitals, which is a cardiac diet, where the only stipulation is less than 2 grams of salt. That's not going to cut it. You're still going to get cheesecake and spaghetti and meatballs potentially on your plate. So they would have a default diet that would be healthier, and they would have the ability to be referred to nutrition both in the hospital and upon discharge into the community. And depending on where that hospital is located, they might have nutritionists living in the community, but it might be a resource-poor area. And so Medicare and Medicaid would also pay for the ability to have a tele-encounter where the nutritionist could review that person's food diary and provide follow-up, because similar to what we see with smoking cessation programs, you can't just tell people stop smoking, here's a brochure, good luck. You need that follow-up because you're going to see them in clinic and they're going to say, well, I relapsed, what can I do? And you find out, okay, what was your barrier? How can we get you back on the wagon? And you need the same thing in nutrition, because our diets, similar to smoking, are so ingrained into the way we live our lives, our cultures, our backgrounds, and it's not as easy as just adding another pill onto people's medication list.
Thank you. And so few and many people don't know how to cook anymore.
Yeah, many people don't know how to cook anymore. I actually, it hasn't come out yet, but I just did a video for this nonprofit called Eco America. And one of the things I talked about is, we have this infographic on eating healthy, but one section is, once you go do your shopping, take your kids with you and put the kid in the cart and tell them, you're going to help me do the shopping. Go ahead and put things in the cart. And as they put things in the cart, you ask them, why did you make that choice? And see if they can identify real food. Can they identify whole foods? Once they're old enough, can they do a basic interpretation of a nutrition label? What sort of things are they looking for? And so you're teaching kids how to shop, and it's something you're doing anyway. And then once kids are old enough, they should be helping in the cooking, because if mom and dad do all the cooking for them, they're going to go to college, they're going to be young adults without the skills to cook for themselves. And so they're doing takeout, they're doing food delivery programs, and that's a lot of money that they could be saving for other things. And I think it's a skill that's been lost now that we don't have things like home economics and shop in our schools anymore, the way we used to decades ago. You need these life skills just to teach people sustainability, self-reliance.
Thank you. Here's a question. How about exercise? What are your thoughts on living an active life?
So, of course, similar to diet, exercise is super important for the prevention of a lot of chronic disease. But, I tend to prioritize food more because a lot of people think that it's a scale where they can just, have a bunch of junk food and run it off. And really, that's not the case. It's not as simple as calories in, calories out. So I definitely encourage people to exercise, but I tell them, I'd rather you be a plant-forward couch potato than eat a bunch of burgers and then work out at the gym 3 hours every day, because it's not going to work out in your favor. Even if people exercise to the point where, physically they look okay, they have a lean body mass, they're muscular, well-toned, that doesn't necessarily mean that metabolically they're doing well. They can still have a high significant burden of plaque. They can still have high levels of inflammation in their body, and eventually that will catch up to them, even if they don't develop overweight or obesity.
Thank you.
And then I have a question.
Please.
So what would be your recommendation if you have a patient sitting in front of you, single parent, works 2.5 jobs, doesn't necessarily have the time to be able to go home and cook a nutritious meal?
Yeah, and that's a barrier for a lot of people, whether they have kids or not. Some people just don't really have the time to cook. And so at that point, they have a few options. They would look at places that serve healthy food and get delivery from them. They could have meal delivery programs, but the problem is that it usually costs more than cooking. And this is one of the social barriers we have, because if someone has several chronic diseases that are diet related, why is it that we are subsidizing their medications and their physical therapy and any procedures they may need, but we're not really subsidizing their food? Why is it that we can't have food delivered to their homes for them, where it's not a huge financial burden for them? And there are places around the country that are beginning to do this. So the stroke center at Rush actually has a food delivery program, and there are other centers not working on stroke specifically, but other conditions like cancer. So Memorial Sloan Kettering is now supplying people with the food they need as part of a clinical trial. And I think as we accumulate more evidence for clinical trials showing that this is something that people are actually going to eat, it doesn't necessarily have to be all their food. It can just supplement their food. They can still do some cooking or shopping on their own, but it's at least supplementing their food. And it's cost effective and saving healthcare dollars down the road. I think that can pave the path to having some equity when it comes to food and being able to help people that don't really have the resources to do the cooking on their own.
Thank you. Yes, I can see food pharmacies and food delivery systems. And California now, as you know, pays for CMS paying for food delivery for people who have food insecurity. So do you think we need to control for diet in cholesterol/statin studies?
Sorry, control for cholesterol in statin studies?
Do you need to control for diet
Oh, okay.
in cholesterol statin studies?
So, it would be nice to kind of sparse out the data, but the problem is with any nutrition trial, it's just fraught with so many confounders. Because for you to really have a controlled studies, you've got to lock people in a building for 10, 20 years and feed them all their food, right? So it's just, It's prone to confounders. It's going to be difficult. And I think we're going to get more usable data from real world settings like what Memorial Sloan Kettering is doing, where they're partially supplementing people's food and saying, okay, we're giving them some food. We're not going to have a clinical trial where we're supplying them all their food, because realistically, that's not what's going to happen if we have subsidized food programs. So I think having correlational data from more realistic trials like that is probably going to be more helpful and better at informing public policy.
That's a question. So great talk. One thing that I was thinking about, we know from delayed discounting research that we delay or we discount both rewards and consequences that are down the road. So the benefits of our good choices don't happen immediately, and the consequences of our bad choices don't happen immediately. So we eat the donut today, we use the plastic water bottle today, because we're not immediately seeing the effects of those things in our lives. Are there things that you would recommend doing, or things that you do in your practice or based on your research to help bring those, later benefits or consequences more to the forefront of your patients' minds? If you make these good choices today, these are the things that are going to be beneficial for you, rather than having people follow their natural line of thinking where things just seem so far in the future that they discount it and it loses its value or meaning.
Yeah, no, I understand what you're saying. And I think for patients with neurological conditions, it is harder than patients with heart disease, because one of the things that Dr. Ornish showed with his heart data is he puts people on these lifestyle interventions and immediately they have less frequent angina. They have the ability to walk more steps without losing breath. And so they see that change within days of radical dietary changes. And radical dietary changes means you're not just adding an apple or a salad to whatever you're doing every day. You're radically changing what you're eating and how you're moving and how you're relating to other people. And we don't really see exertional dyspnea and angina in our stroke patients. So it definitely is harder. And I don't think we can appeal to them in the same way. So I think rather than, some people will say that they have an immediate benefit and they'll just feel like their thinking is clear, they're sleeping better. I think that's the exception to the rule. I think we have to appeal to people in other ways and show them, look, this is how you're going to actually save money down the road. Or if we can get insurance to pay for following up people's LDLs or the A1C within a couple of weeks of making these changes, we can show people, look, your blood pressure is lower, these numbers are better, and just show them very concrete things that they can really hang their hat on and kind of inspire them to continue doing what they're doing. And I think if we can't necessarily show immediate change with neurological outcomes, a lot of these patients have comorbid conditions like ischemic heart disease, like heart failure, like diabetes, et cetera. And we can show them, oh, you're getting lightheaded on your blood pressure medicine. You probably need less blood pressure medicine right now. Your sugar is not spiking as much. And so we can use these other markers and show them that these other health conditions that are actually the cause of your stroke are getting better. So you are effectively reducing your stroke risk, but in the short term, you are feeling better and requiring less medication.
Thank you.
And then there's a lot of kudos to you. Congrats on a wonderful talk.
Oh, thank you.
Awesome lecture. I don't see any other questions here in the chat, and we have reached time. So you can see how to claim your credit in the chat as well. And again, thank you, Dr. Ali Saad, for really a wonderful talk. Lots to digest and marinate in.
Of course, thank you so much. And I'm just gonna keep this up in case people wanted to scan it. Just leave it up for a few minutes. Thank you again, everybody.
I'm sorry if there was a little feedback from the